This is Healthcare Now Radio's Talking the Walk. Come along with us as host Tom Testa and his guests discuss the strides being made toward actionable changes in the industry. It's a fast-paced 30 minutes, so keep up. And now, here's Tom Testa.
Hello, everyone, and welcome to this special episode of Talking the Walk. I'm your host, Tom Testa. This show is all about diving into real conversations that inspire, challenge, and move us forward. No shortcuts, just authentic journeys. Let's take that first step together and start walking the talk. Recently, Healthcare Now Radio organized and presented a virtual event titled Sharing Health Data, Challenges to Solve, Lessons to be Learned. In today's episode, we'll tune into one of the sessions called Driving Efficiency and Cost Savings Through Closed-Loop Referrals, Interoperability Lessons from UPMC. You'll hear moderator Mike Gordon, Senior VP at Secure Exchange Solutions, joined by Dr. Kristian Feterik and Dr. José Francisco Abad from UPMC in Pittsburgh, as they discuss how UPMC leveraged IT investments to develop an automated, closed-loop referral system integrating EHR physician consults with a centralized intake department. Let's dive in.
Fantastic. Thank you very much. We are extremely excited to be here today to talk a little bit about some innovative solutions that UPMC has implemented. I'm Mike Gordon with Secure Exchange Solutions, where I am SVP and Head of Product, and am thrilled to be joined today by Dr. Kristian Feterik and Dr. José Abad from UPMC. I thought maybe we'd start if I could just ask Dr. Feterik and Dr. Abad to briefly introduce yourselves and describe your roles at UPMC.
Mike, it's such an honor to be here today, and thanks to Answers Media for inviting us as well. Jose and I, we probably represent a little bit of a different spectrum of healthcare. I am a hospitalist, and I also oversee our enterprise interoperability for UPMC, so I work as a physician informaticist. Jose, over to you.
Yeah, I'm on the flip side. I'm a primary care doctor in ambulatory settings and in an academic setting, but we both work on the same team with the medical director of informatics on kind of the needs of our organization. But I'm very happy to be here as well, and thank you for the invitation and the opportunity to participate.
Our pleasure. Thank you for those introductions. I thought maybe we could start by asking you both to provide a little bit background on UPMC and how the need to share data and some of the drivers behind your focus on interoperability and how that correlates to your overall healthcare strategy.
Yeah, thank you for that question. At UPMC, we are in large integrated delivery and finance system. We operate in 3 states, Pennsylvania, New York, and Maryland. We have 42 hospitals, 800 ambulatory centers, including 60 cancer centers. We operate multiple electronic health record applications with an overarching intraoperability solution. And we are members of Care Quality Commonwealth Health Alliance, eHealth Exchange through our regional health information exchange organization called Clinical Connect HIE. And we have been at implementing electronic health records since the late 1990s, so over 2.5 decades. Jose, if you'd like to maybe add anything to it.
Yeah, I'll put some color. I got here to UPMC about 3 years ago, and I started out in a northern part of Pittsburgh. And as a primary care doctor, you get kind of a full breadth of different streams of information. And so, I was on an Epic system, documenting and looking at patient records. And then I'd see their records from, hospitalizations and, realizing that, we had a Cerner instance for our inpatient side and an Epic instance for our outpatient side. And it was seeing all the kind of interoperability in action when I would get, discharge summaries from the hospital or the hospital visit stays. And then I thought that was it. And then I had a patient who unfortunately was dealing with an active cancer diagnosis. And I was like, well, where's all your documentation? And so we have a third, important EHR system, ARIA, which, houses most of the cancer patient documentation and how they're dealing with. And so luckily, luckily, we had a very robust way of what I was realizing at that time with direct secure messaging, and I was able to get all the really necessary information from hospitalizations and especially about lab results. But it definitely, for someone who had been at institutions like Kaiser Permanente that was completely Epic based, it was a new world for me. Interoperability was probably more care everywhere than it was any real interoperability. And so the true strength of UPMC when I first got here was in that interoperability of getting that information to a primary care physician from all those streams of resources. And sometimes actually the information that came from the Cerner system was almost better organized than even I've seen it in Epic at times. So it was interesting that you could get a discharge summary that would go, right to the top, and it'd be very clear. And the way the style of the text was easy to read, and but it was unique being here. We do have for whatever reason, a lot of my patients would also go to Allegheny Health Network for their women's health related issues. And so, I'd be using the Care Everywhere for accessing imaging and PAP results for my patients from that perspective too. So it was almost like 3 streams of information through my email, through Care Everywhere, and then through, the Epic program taking in these direct interop, messages from the Cerner instance that we've created over time. Well, that Kristian has created over time.
No.
Yeah.
Yeah, thanks for that, Jose. Yeah, absolutely. I mean, internally, we exchange about 27 million messages a day through our interface engine. Externally, we send about 10,000 some messages to Commonwealth Health Alliance, and probably about the same, if not a little more than that, to Care Everywhere.
I don't know if you remember, Kristian, when I first started, I think you sent me I was getting into the clinical informatics realm after Tony Fiorillo, and you probably didn't know me as well as we know each other now, but you sent me an email like encouraging me or, almost mandating me to sign up for direct secure messaging. And so I still remember vividly, I was like, oh, my buddy colleague is really on me about signing up for this, this thing, quote unquote, as a primary care doc, that I would say, why am I being, requested to sign up for an email? I don't want more information. But it was very gentle and purposeful. And, it's a small little email, but it's so critical to how you deliver care at our institution. It was just, I kind of laugh about it because I experience it, as both a clinician and as an informaticist.
Very interesting. Those numbers are astonishing. I'm thinking maybe we could shift gears a bit and talk a little bit about UPMC's closed loop referral solution. And I understand it's been tremendously successful. Maybe I'll ask you to just share a little bit about that initiative and what some of the primary drivers were behind building and implementing that solution.
Oh, absolutely. As Jose had said, we had strategy-wise early on decided that it was important for the organization to have a central health information services provider. It was crucial for us to do that. And not only to fulfill conditions of participation for ADT notifications for our Medicare beneficiaries, but also to look for some custom solutions that our clinical partners demanded. Because first and foremost, I would like to highlight that the workflows and processes can only be improved or enhanced if in fact we map them out and then we back them up by strong technology like a HISP can provide for direct secure messaging. And so in 2019, and I don't know, Jose, if you were, forgive me if you were there already, but that's when our partner, Dr. Fiorillo, was our, probably both of our mentor, had really helped us spearhead a project in which there was a significant amount of time spent on arranging for home healthcare services for our ambulatory patients from our ambulatory electronic health record solution, up to the fact that on an average, we spend about 97 minutes for one home care referral. And so working with our community provider services team, as well as our interoperability team and our Epic analysts, we had created a solution in which that process was simplified down from about 7 clicks to 3, and down from about 97 minutes per referral to 11. And more importantly, direct secure messaging was pivotal for us to essentially, Mike, as you said, to close the loop. Because prior to the project, we have not been able to notify the primary care physician or the referring physician about which home care agency the patient selected. To make it clear, we were not notifying them electronically, and certainly no one likes faxes. But our goal for the project was to essentially have an electronic order going out from the electronic health record system to our community provider services team, arrange for a home care agency, and then have a closed loop referral electronic order coming back to the message center, or as we know it as the in-basket of the referring physician.
Very interesting.
I think a testament to that is that I came probably 2021 to the organization, and I have no idea what he's talking about. It's been seamless since I've been here. So the hard work didn't even, you do get the what is it, the chart deficiency, Kristian, where you do have to sign the order, which is integrated into our EHR, but it's a very easy process to execute.
It sounds like a very streamlined, highly efficient process. Kudos to UPMC for implementing such a value add solution. I'm kind of curious if after the initial deployment, were there any enhancements or additions or changes you made to the solution over time based on learnings in production?
Yeah, certainly, Mike, we wanted to look at what's the most important value for the referring physician. And so not only we provide information regarding the ADT message containing the patient demographic, start of service, but also the plan of care for the physician. And so now this is all integrated in the electronic health record as opposed to a flat file scanned image that perhaps no one can take action on. And I think the other use cases that we have been looking at was how can we expand this to other referrals, for example, hospice or other home care types of referrals as well.
Very interesting.
And I mean, Kristian, you can comment on this, but I don't see this going away. We're going to have to create a solution for this, in the future with our change to EHR, because home health isn't always exclusive to the organization you belong to. It's always county dependent, or, within a city, it could be, dependent on other factors. So this hard work will kind of benefit even for our future state with our movement to a single EHR.
Well, I'm glad you mentioned that, Jose, because actually in our first year after deployment in 2020, what had happened is not only we were able to cut down on the steps that are required for a referral, improve the communication, but also decrease the amount of time that we were processing the referral. We also had increased the number of home care agencies that we interacted with by about 30%. So we not necessarily had narrowed it down, we were able to actually expand.
Yeah, it makes me wonder, physical therapy always tends to be one of those similarly challenging scenarios where there's resources that you have part of your organization, and then people like to go to that one mom and pop shop that's owned by a DPT, and I don't think we have that. But is that in the process or considered for some kind of similar workflow?
I mean, I think that certainly that's something which we can always look at, because the framework is already in place. And so in order for us to expand to another use case would be a fairly low lift.
Yeah. Well, I don't mean to give you work, Kristian, but that might be a good thing, because the number of faxes that I get from home health has dropped, but the number of PT faxes is about the same. So, but yeah.
I mean, I think one thing, Mike, and Jose can comment on this as well, that we have been receiving feedback on, especially from family medicine and from internal medicine, from our primary care partners, was perhaps the number of these types of electronic messages that are now coming to the in-basket or to the communication center. We are still living in this hybrid world of faxing or electronic faxing, and in a world where more and more notifications are coming through direct secure messaging to the in-basket. How do you align processes in the office around them? How can you perhaps configure your support staff or rearrange your support staff or your pool so that the individual clinical practitioner is not necessarily feeling overwhelmed, especially perhaps if they're cross-covering or covering others who may be on other duties or out of the office. I don't know, Jose, how you manage that in your practice.
In terms of the inbox management of it, I mean, luckily, because of how the inbox is divided into those folders, the coverage historically has always been focused on like more of the urgent things. So it is one of those things that probably hangs out in the in basket for you to get back from any kind of vacation or time off, unless like it's time sensitive. Luckily, a lot of those don't tend to be too time sensitive, but it does come in its own subfolder that makes it easy to acknowledge, what you have to address. It made me wonder, there must be things that exist from an intraop position that I don't even think of. Like if I put in an order for an X-ray from Epic, there must be something, hitting, the radiology department if they're on Cerner. Is there something, that it's been built in that regard? Because now that we're talking, I've never had the opportunity to ask you that before.
Well, I think that's one of the things that we're looking at. As you had mentioned, we are on a journey to transition to a single unified electronic health record. But often the electronic health record is something that our clinical partners don't realize how much the system is supported by departmental, foundational, maybe some other bolt-on applications.
Yeah.
So in fact, even if we anticipate that order is going from one system to another, it does not necessarily mean that it will reach the other system electronically, but sometimes it still prints out on a printer and someone picks it up and inputs it into the other system.
Yeah. It kind of speaks towards, what we were dealing with when we made the decision to, have a single unified EHR. It's at what point does the extreme of interoperability get pushed? And I think, the movement towards a single EHR for us was because we are kind of hitting maybe not the technical extreme, but the volume extreme, the number of patients that we care for, the number of hospitals we have, and the number of health system or outpatient offices is getting to the point where without having a single EHR, that interoperability is being pushed to its challenging point. And so, that's I think why UPMC has ultimately decided to go with one. From what I understand, and you can correct me, but I was under the assumption for many, many years, we were always a best of breed. We liked to go with, the program that was the best of breed, that had the most functionality, and we could figure out the interoperability. We knew how to take care of the technical challenges of interoperability. But I think now with our growth, we've hit the can't do the best of breed anymore. I don't know if you have a similar thought process on that for our history.
You're absolutely correct. And not just that, but I think that having or implementing best of breed applications may have worked in the past. And maybe there are organizations out there for whom it still works just fine.
Yeah.
At least for us, having multiple hospitals, doing the maintenance and keeping the lights on is taking up now so much time that really I think it perhaps is at the expense of some innovations. I think we'll be able to innovate even more once we have that technology stack simplified. Because Mike will probably agree with us that even being on a single electronic health record system does not always solve interoperability issues or challenges.
Absolutely. That is not a panacea either. There's always going to be issues with sharing data across the different instances and different configurations. Question or comment made me think of one other topic, that there's sort of this long tail of legacy data, legacy communications. And it's, when I take a step back and think about it's almost year 2025 and the amount of faxes that are still a very common part of our workflows within healthcare, it sort of blows my mind as a technologist. And we do have some customers that are trying to bridge that legacy world with the more modern, digitized electronic world of interoperability by taking those legacy faxes, capturing them in flight, and turning them into direct messages using OCR to extract the clinical data, and in some cases, creating a CCD document that can be consumed by an EMR. So that could be an interesting conversation for another day, perhaps. But
Yeah.
this is a wonderful discussion. I think we have time to maybe squeeze in a few more questions. You you both had already mentioned some of the business impacts of this closed loop referral system. You're able to spend less administrative time in processing these referrals, which benefits obviously UPMC, but it has direct benefit to the patient as well, because you can get them placed in their home care that much quicker. I'm curious if there's other business impacts that you've realized, whether that's reducing leakage outside of UPMC or other ways that you think about the value of this kind of solution.
Well, I think that having that relevant data at the point of care, not just for the referring physician, but the entire team, the office as well, maybe Jose can back me up on that, is also crucial. What we had created with this process was also to have a single point of contact for the entire organization. So this way, even though we had increased our number of home care agencies we interact with by 30%, we had consolidated that point of contact to a single phone number instead of every single of our ambulatory offices making phone calls one by one, which was quite inefficient. Having that central call center also helped tremendously. And this also then I think ties in and increases our ability to be agile with any changes in regulatory requirements.
Yeah, I would only add that I think for the patient experience, having this system really makes it easier for us to help them navigate it versus, kind of having them fend for themselves, not knowing what to do next. We're able to help manage that workflow and process.
Fantastic. So maybe shifting gears a bit once again, and now looking forward with relatively new standards coming down the pipe, such as Direct Trust 360X closed loop referrals as a standard for using direct messaging to facilitate EMR to EMR referral processing. Is that going to impact your ability to scale the current solution? Have you thought about 360X? Or maybe part two of the question, are there other standards that are top of mind as you think about in coming years how you can continue to grow the adoption of this type of solution?
Oh, that's a great question, Mike. And certainly, I just want to highlight and big shout out to Dr. Holly Miller, who has been a big proponent of 360X now for a while. And also to our EHR vendor partners. We have 2 Epic instances right now. We actually had just acquired some practices that are ECW, eClinical Works. And so certainly that is a standard that we are evaluating and actively looking at because of the fact how it leverages direct secure messaging and the closed loop referrals that can happen between unrelated electronic health record systems. And maybe perhaps to others, Mike, that we would look at. I know that Dr. Tripathi had mentioned FHIR and how much the ONC or ASTP is promoting now fast healthcare interoperable resources. And if we think about it as a language of interoperability, then certainly that is going to be the future, not only connecting between healthcare organizations, but also between healthcare organizations and perhaps guarantors or health insurance companies, and also the patient or the others as well, public health agencies.
Yeah, there's a project right now being floated. We were working with a third-party vendor who was utilizing natural language processing to help us risk categorize our patient populations based on their HCC diagnoses. And one of their their partners kind of stopped a stream of service and eliminated what was like a flat file exchange. And so we, had started out the conversation about, resuming the flat file exchange in a different way, and soon pivoted to just a FHIR API instead. They found opportunity with the support of Epic to create this FHIR API to be able to exchange, this information that is needed for the risk stratification. And so it seems like more and more conversations that I'm having with our third-party vendors used to be, let's set up a flat file, to now, let's work on a FHIR API. And I don't think our analysts are too excited about it, but from the standpoint of being able to integrate with this new company and have something that is much more dynamic will help out with this risk stratification that we're trying to present to our physicians. We want them to have the benefits of this third-party natural language processing to, give them the most granular HCC diagnosis possible. And we're utilizing Epic's expertise on, what they've built on with their Care Everywhere. I mean, they have basically worked on this for years, trying to be able to create some interoperability. I think, if I'm not mistaken, I think Care Everywhere was because of Kaiser in California. Like the northern and southern instances of Kaiser needed to talk to each other, and this was so long ago that Epic was like, I guess we'll build it for you. We'll build you an interoperability. It's becoming so crucial that for this integration that it's now, the first thing you're considering when you're doing an upgrade. And, so we'll see how long. I don't think flat files will go away, but we'll see how long they last in the majority.
Yeah, I share your enthusiasm with FHIR. I think we're going to see a lot more. I think the industry's been talking about FHIR for a number of years now, but I think it's now mainstream, and we're going to start to see much more broad adoption of it as a simple standard for data exchange.
Does anybody else hear Bill Hirsch's voice when they say smart on FHIR? I think I've heard that man say FHIR 1,000 times.
Maybe in closing, I could just ask you, are there any words of advice that you would offer other hospitals or health systems when they're thinking about interoperability and evaluating solutions in that area?
Mike, I would say that it's really important from a strategy standpoint. Know your internal and your external customers. See what's important for your clinical partners and perhaps your non-clinical support personnel as well. How can you leverage existing technology? There are great companies out there who you can partner with, and at the same time promote the work processes inside your organization.
Well stated. Thank you so much for having us today.
Thanks for joining us today. You can find the entire virtual event on Healthcare Now Radio's YouTube channel. You can hear Talking the Walk weekdays at 8:30 a.m., 4:30 p.m., and 12:30 a.m. Eastern Time. You can also find all of our episodes on the show's program page on healthcarenowradio.com. If you are someone who is walking the talk, we want to talk to you. Connect with me on LinkedIn or by filling out a contact form on healthcarenowradio.com. Until next time, keep walking your talk. I'm Tom Testa. Take care, everyone.